I'm very happy to be the one introducing Emma. She will give us the last lecture here, and hopefully it's an optimistic journey through transplantation. Okay, so hola, me llamo Emma. Clara's been teaching me Spanish. I'm very, very good at it now. Okay. I'm going to talk to you about stem cell transplant, allogeneic transplant for patients with inborn errors of immunity. And I'm actually an adult transplanter. So most of the talk will be about treating adolescents and adults, but I will cover a bit of pediatric data to start. There are now nearly 500 genes that have been recognized that are monogenic causes of immunodeficiency. You all know that. Why am I telling you that? Because who out of those patients who have one of those genes is it appropriate to transplant? Who? Hey, come on. I can't pronounce any of those, but anyway. ¿Quién? ¿Cuándo? ¿Cómo? ¿Por qué? There you go, you see. But this is really, really important, actually. This is like the whole point of transplantation for inborn errors of immunity, for immunodeficiency, right? Because in one sense, you could just say, let's transplant everyone. And, you know, some of them will die and some of them will get better and some of them actually may end up with some nasty immune complication of transplant, like chronic GVHD or impaired immune reconstitution, and basically have a crappy immune system just like they had before their transplant, you know? So actually it's really important to understand these four factors. So I hope that I'm going to provide some information to help with that. The other reason it's important is if you're a transplanter, there is a tendency to think of immunodeficiencies other than SCID, that is fatal in the first year of life, as being a, inverted commas, benign disease compared to acute leukemia, compared to multiply relapsed lymphomas, other malignancies that most adult transplanters, that forms the bulk of their patient population. But actually, immunodeficiency are not benign diseases. You know, if you're a pediatrician or a pediatric immunologist, many of your patients will survive to transition to adult care, but actually they don't live to be my age, and I'm in my mid-50s and I consider myself incredibly young. Actually, I'm not that young and I'm feeling a bit old these days. But actually, when you look at these survival curves, you know, these are terrible, right? People don't survive to middle age. So remember that. These are diseases where it's important that we can offer or develop or at least consider a potentially curative option. Okay, it's worth thinking about it and it's worth understanding whether that risk is appropriate. So allogeneic transplantation for babies and young children is extremely well established in immunodeficiency. And the outcome data is really excellent. So these are three quite recently published series within the last 2 years. So for example, this is allograft data for patients transplanted with ADA SCID. This is a big European study looking at allograft data for patients transplanted for Wiskott-Aldrich syndrome. And here, this is a little bit older. It's sort of 4 years old now, but this was a very big study of 700 patients with chronic granulomatous disease. And these are really outstanding survival curves, okay? But two people have already mentioned that it's not just about the overall survival. And the other thing I want to highlight today is that if you are an adult immunologist or an adult transplanter, many of the patients who transition to your care, who could be in their early 20s, their late teens, and were transplanted 15 or 20 years ago, were transplanted with a procedure at the time was considered state of the art, the best available conditioning, the one with the most data to support it. But actually, what we found is if you look at how these patients are doing as adults, many of them, they're alive, which is great, but actually, they're not actually fixed. And I think, Gigi, you presented the PIDTC long-term follow-up data for the SCID transplants, where you saw that cumulative events curve just continuing to progress. So we did with our, we're kind of like the adult half, the grown-up part of Great Ormond Street Hospital. So, you know, they transplant lots of kids with immunodeficiency, and we mop up all the mess when they survive into adulthood. And I say that jokingly, but I'm teasing them all the time. Could you do this a little bit better, just so you could fix more of these people? And we did a landmark analysis of 83 patients. And of course, their survival was, because it was a landmark analysis, it had to be alive to be in the study. So of course, there's some statistical bias in this. But actually what you find is their event-free survival, which is the blue curve, actually from about 10 years post-transplant, gradually starts to reduce. Now, this is out to 30-year follow-up here. So when you see transplant outcome papers published, most of them, even when they claim they've got fabulously long follow-up, maybe the median follow-up is 5 years in big studies, and it goes out to maybe 10 years. This is important because actually what happened, these people are still in their mid-20s, right? They're expecting to get a job, settle down, buy a house, have a normal life. And actually, you know, they're coming in and out of hospital and they have a number of complications. So we were able to analyze these. And as with many other studies, we found that the key factors were how old you were when you were transplanted, which as an adult transplanter, I always find a kind of annoying to have to admit that actually patients do better if they're transplanted when they're younger. It's a bit annoying, but anyway, it doesn't mean I should stop trying. And also whether you can achieve really good chimerism post-transplant. And this is important because previously, when these guys as pediatric transplanters were transplanting infants and young kids, they would try and use as little conditioning therapy as possible because they were worried about the toxicity in sick babies who had active infection. And actually now we know that if you don't condition them, you don't get really good engraftment of hematopoietic stem cells, and you don't fix all your compartments. So you may get brilliant T-cell engraftment, particularly obviously in the SCID babies, because there's a vacuum in which these healthy T cells can just proliferate. They have an amazing advantage. But actually the myeloid compartment, and in many of them, they never reconstitute B cell immunity. So they end up a bit like a CVID patient or even an XLA patient. And then we're now seeing them develop nodular regenerative hyperplasia in their 20s and all the kind of hepatic and pulmonary complications we see in patients with B cell defects. We were also able to look at the different subgroups of patients and find some of the factors, again, which were basically age and peripheral blood chimerism at 5 years post-transplant, so quite early on, which could predict for these very late outcomes. And I won't go into this in detail just because of time, but when you look at the chimerism, when you divide the patients into underlying disease groups like SCID, combined immune deficiency, and phagocyte disorders, this here is what I was telling you about the fact that many years ago, these SCID patients didn't have conditioning, and so they don't get decent myeloid engraftment, but they get brilliant T-cell engraftment. Okay. So actually, the reality is that not all patients with immunodeficiency, even if it's severe, are transplanted as a baby or in childhood. It could be because they weren't diagnosed at the time, they had an atypical presentation, or there were confounding factors that meant they presented later on. Sometimes genetics wasn't available, so they had a constellation of clinical symptoms, but actually nobody had nailed a diagnosis. And obviously, again, playing this shifting sands story that 15 years ago, people didn't want to do a matched unrelated donor transplant in a small child or a mismatched unrelated donor transplant because the outcome data was appalling. Whereas now the outcome data is equivalent to sibling donors. You know, you can do a haploidentical transplant, you can do a mismatched MUD, you can do a MUD, and the curves almost overlay each other if you're being transplanted in a big center with good experience. So many parents were advised not to take their child to transplant at that time. Okay, so when should we do it? Well, we should do it, and this is really flippant, we should do it when patients have demonstrated they've got a severe clinical phenotype, that they're sick enough to warrant the risk of a transplant, but not before it's too late. So the picture here is like falling off a cliff, right? The sudden deterioration unexpectedly, often liver disease, development of ascites, ruptured esophageal varices, or just the long, gradual, almost unnoticeable progressive end organ failure. You know, 3 or 4 respiratory tract infections a year. You know, you do your CT of your chest every 5 years. You try and do lung function every year, but your patient doesn't turn up. And so you've missed it for a few years, and then they miss another couple of appointments. And then eventually you realize that their lung function is appalling. And actually, you've probably missed the opportunity for a safe transplant. So there are a number of very clear indications for transplant, obviously life-threatening infections, HLH, malignancy, uncontrollable autoimmunity, and autoinflammatory diseases. They're complex decisions. There are many variables that relate to the patient or the disease, and I think the biggest one that I struggle with, and why I do my clinic jointly with an immunodeficiency immunologist, is because we have to work out what is known about the natural history of the disease without transplant. Because if you don't know that, you don't know whether the transplanting someone is actually going to improve their outcome or not. And the thing about this is that it's really important that everyone publishes their cases, even if they're case reports, because otherwise we don't know what happens to these patients. And it's also important that we publish long-term outcomes for patients, whether they're transplanted or untransplanted. A very complicated issue is the fact that in some diseases or with some genetic mutations, there's incomplete penetrance within families, so the clinical features can be very different, and there can be phenotypic heterogeneity in a same kindred. And so it's hard to know, just because an older sibling had a catastrophic death when they were 18 doesn't mean everyone else in the family is going to die when they're 18 and you have to do the transplant before that. In adult immunology, we are identifying lots of patients with variants, and in theory, unless you've functionally characterized it and proven that it's causative, it's quite hard to justify the transplant unless you have overwhelming clinical features. And then I won't go through these, but there are various transplant-related variables. Siobhan Burns and I published a sort of review article in Blood a couple of years ago, evaluating factors that are important in making decisions. Again, for the purposes of time, I won't go through that in detail. So here's some multi-center retrospective data. Now, this is looking at, I'm being rather loose with the term adult. This is older adolescents and adults. So these were patients in Europe with immunodeficiency who were transplanted at the age of 15 or above. And I think that's okay, because when you look at the pediatric transplant data, the median age of those cohorts is usually less than 5 years old. So they're a very different group of patients. So what we were able to identify and write up is 329 of these significantly older patients with an age range between 15 and 62 years at transplant. We were able to look at overall survival and event-free survival and rates of GVHD. And we looked at things like the subtype of immunodeficiency. So in green are phagocyte disorders. So a lot of these are CGD patients. We plumped the GATA2 patients in with that, and there are a few rarer innate defects in there. The red line are the combined, this is a really weird blob that I feel I have no control over. But anyway, the red line are combined immune deficiency patients, and the blue line are predominantly antibody defect patients. So that's XLA, there's a few APDS in there, and there are CVID patients. And these ones do badly, and remember that. So at the moment, we don't have really good data to support the role of transplant, particularly in CVID in adults. What wasn't important actually was how old you were. Okay, so what mattered was in what NIC you were in, how good your clinical condition was, and how many complications you had related to your immunodeficiency. And then we looked further at particular inborn error risk factors. We looked at things like bronchiectasis, hepatic comorbidity, splenectomy, and looked at the impact of these complications in the whole cohort, but also in different subgroups, and looked at the particular factors that influenced event-free survival. And it won't surprise you to know if you've got established bronchiectasis, if you've got a rubbish liver, if you've got multiple complications, and if you've had a splenectomy, your event-free survival is much worse. So that was a big retrospective multi-center study. We also, with our colleagues at the Necker Hospital in Paris, tried to do a direct comparison. No one's done a prospective randomized control trial in older patients. In fact, transplanters are really rubbish at doing trials. Most transplanters transplant people the way they like to do it. They get familiar with their regimen, they get good at it, and they don't really like to countenance ever using anyone else's regimen. So I think we've had a poor track record in trials, and actually I think the Seaside trial, if you get recruitment to that will be really important. But here we had 79 index patients, again, who were over 15 at the age of transplant, and we tried to match them. We matched up to 3 control untransplanted patients, and they were matched on age at diagnosis, type of immunodeficiency, number of immunodeficiency complications like autoimmunity, autoinflammation, malignancy, lymphoma, cytopenias, and kind of era of diagnosis. So you could have a bit of a contemporary match for their treatment. So we had a whole cohort of 281 patients. And what we were able to demonstrate is that the patients who underwent allogeneic transplant achieved a plateau. So that cumulative acquisition of events, which you see here in the blue line, you can actually achieve an improvement in cumulative inborn error complications. The problem with this data, so I'm not, although I'm a believer in transplantation, we haven't fixed this bit here. So we haven't fixed the transplant-related mortality, the early transplant-related mortality. And I think some of that will come through better conditioning regimens, more experience with these particular patients, but it will also, it's why I think the patient selection is so important. Okay, so I'm just going to finish up with a bit of data from our own UCL cohort, and this is data from 82 adolescent and adult patients with immunodeficiency, and you can see their range of diagnoses here, who underwent transplant, allogeneic transplant in our centre. So this is the caveat here, it's a single center study. Most of the patients had matched unrelated or mismatched unrelated donors. They almost entirely had reduced intensity conditioning regimens. And In our entire cohort here, our overall survival at 3 years was 90% and event-free survival 72%. So we're still not fixing even all the survivors. There are still complications related to transplant. We've done a bit of data massage here because everyone likes their data to look a bit better. The justification for looking at the 74 patients that have been transplanted since 2010 is not just because the outcome is better and it makes us look better, but that's when we started running our service in conjunction with the immunologists and running joint clinics. And I think that's really, really important. And we again show no statistically significant difference between the 19-year-olds and over and the 13 to 18-year-olds. We're able to show using different types of scoring systems that evaluate the degree of immune dysregulation and immunodeficiency. For example, there's this IDDA score that was developed by Marcus Seidel in Graz, and we're able to demonstrate that this can be reversed post-transplant, that patients' colitis is resolved brilliantly after transplant, and most patients have a significant reduction in infectious complications post-transplant. And then we are able to evaluate the impact of the HCTCI score. So it's a standard comorbidity score, and the patients with low comorbidity scores obviously do better, both in overall survival and event-free survival. And we can, here, overall survival and event-free survival. So the patients with the high HCTCI scores do really badly, okay? Quite a few of them survive, but their quality of life is rubbish. And these are the patients we need to think really hard about whether this is the right thing to do for them. And then we evaluated the IDDA score in trying to look to see whether we could whether this would be a better predictor because it's immunodeficiency specific. And then Tom Fox, who's in the audience, has done some nice work to try and group our patients into sort of 4 groups. So we have a group that have high HCTI score and a high IDDA score in yellow, and they do really badly. And I think I would argue that we shouldn't be transplanting these patients, even if their prognosis is poor, because dying of a transplant complication is not recommended. It's horrible. And then there are some patients who have a low HCTCI score. So you might just look at them and say, oh, you've got a good risk for transplant, but they've got quite a lot of uncontrolled inflammation or immune dysregulation going into transplant, and they do much less well than the patients whose IDDA score is low. So there's an opportunity there for us to modulate their pre-transplant therapy and improve their outcome. And the point of this, if the animation works, is to show you that there's a bunch of patients who have a low HCTCI score. So as a normal transplant, you'd think, oh, they're a low risk, they're a good candidate for transplant, but actually they've got a high IDDA score. And the point of this graph is not actually a linear relationship, okay? So I think it has something to add. It's a really difficult thing to do because there are 20 parameters and they each have a scale of 0 to 5. So it's hard to encourage people to use it. But I think that in these patients, there's probably a role for that. Okay. So this is one of my patients with his permission. He was a patient with DOC8 deficiency who had terrible cutaneous warts pre-transplant. You look here, his feet, they were completely confluent. He didn't work, he didn't have a job, he couldn't use his mobile phone, he didn't leave his house. We transplanted him. He'd had a squamous cell carcinoma removed. He'd had a malignancy. We felt that was an indication for transplant, and he got worse, and I felt terrible. And then as he finally got decent immune reconstitution at 4 years, 4.5 years post-transplant, his warts have resolved completely. So take-home message there, it's not a quick fix. A transplant is not a quick fix, and you need to manage your patient's expectation. There are alternatives. It's a bit like an insurance ad. Please read the small print. You know, I'm a transplanter, but there are alternatives to transplant. And some of them, for example, in our patients who've got a druggable pathway, like a CTLA4 insufficiency, a STAT1 mutation, you can use a JAK-inhib, you can use abatacept. I think the issues here are the durability of response to these targeted agents is unclear. The toxicity is variable, and it doesn't fix the problem, right? Because their stem cells still contain the genetic mutation and they're still producing immune cells that don't work. There are a number of gene therapies available that are specific for a few well-characterized monogenic diseases. There is no risk of GVHD. It's great if you haven't got a donor, but it's basically almost impossible to treat an adult patient at the moment because of the amount of vector required, the cost. Some of the trials would, you know, if you could treat 4 babies on your phase 1 trial or 1 70-kilogram adult, you'd probably, if you're the CI of a trial, you'd want to treat the babies, probably. I'm not saying that's not true, because when you look at the Wiscott study that I was involved with and the CGD study, gene therapy studies that I've been involved with that were published by Don Cohn and the San Raffaele telethon group, actually quite a lot of those patients were older. And the reason for that is their comorbidities were such that they didn't want the risk of GVHD and having to immunosuppress those patients. So although you have to give busulfan conditioning and you have to ablate the patient, so have to be fit enough for that, there is no risk of GVHD after gene therapy. People like Fabio are now really involved in trying to work out a new model to make these gene therapies available at cost to academic centers. And then gene editing allows us to use things like CRISPR or base editing or prime editing to actually correct the gene in situ, and it remains under the control of its endogenous promoter so that its regulation is physiological. And the advantage of this approach is that you can deal with gain of function mutations, which standard gene addition gene therapy can't do, because you're just putting in a wild type copy of the gene into the hematopoietic stem cell. There's an exogenous promoter that's basically switching it on and it's being expressed the whole time. And so if you have a gain of function immunodeficiency, you can't fix that with a standard gene therapy approach. The major challenge, of course, for these is actually trying to get the efficiency of the editing enough that you can correct enough cells. So, ¿quién, cuándo, cómo, por qué? I don't know, maybe you can answer a few of those now. I think I would like to say that reduced intensity allogeneic transplant is pretty safe and effective at resolving clinical features across a range of immunodeficiencies in older patients. Patients with high comorbidity scores secondary to lung and liver disease have really increased risk of adverse outcomes. I think the IDDA score could be useful to predict overall survival and event-free survival, and we've got a proposal in at the EBMT Inborn Errors Working Party to do a pan-European study looking at that. If you're an adult immunologist and an adult transplanter, work really closely with your pediatric colleagues, because they have much more experience transplanting these diseases. And some of them are quite good fun. And I would recommend discussing your patients, because they're rare, and collectively individuals don't have a huge amount of experience, and we can learn together. Many of you in the room have discussed patients at the sort of case meeting that we run every fortnight, and we discuss cases from all over the world, and we have a mixture of transplanters and immunologists discussing these patients. I obviously don't do this on my own, because I'm not Superwoman, and these are all my brilliant colleagues, and that is where I work. Thank you.